I would like to share my screen. Good evening, everyone. So we have got renowned speaker, Dr. Kamal Kannodia, sir, who is professor and head of Department of Pathology from IKDRC, Ahmedabad. Sir has total experience of more than 25 years. His area of interest is renal and transplant pathology, liver and transplant pathology. Total publications in index journals being more than 50. Book chapters 6. He is a teacher and examiner for PDCC examination and reviewer for various international and national journals. Sir has presented many papers in national and international conferences. He is member of many renowned societies. So we are eager to hear you, sir. We welcome Dr. Kamal Kannodia, sir. Over to you, sir. Thank you.
Thank you, Dr. Radhika, for kind introduction. Good evening, everyone. I thank ISOT organizer for providing this opportunity. Thank you very much. So I'm starting with my presentation, protocol renal allograft biopsy. So allograft biopsies are mainly two types, indicated biopsy or protocol biopsies. Majority of the biopsies are indicated biopsies. The indication for the biopsies are allograft dysfunctions that could be persistent delayed graft function, or there is new creatinine elevation from the established baseline. So there is rise in serum creatinine from the baseline, or there may be new onset proteinuria. So this could be the reason for the recurrence of the disease or sometimes chronic rejection that can lead to the proteinuria. Sometimes there are always chances of detection of the non-invasive biomarkers like BK viremia. This is again for the indication for the BKV nephropathy, or sometimes we detect the donor-specific antibodies. So we should check for the antibody-mediated rejection. So these are few indications for the indicated biopsies. Now the main topic for today is protocol biopsies. So protocol biopsies is biopsies performed around predefined post-transplant milestones regardless of allograft function. So basically these biopsies are performed after certain interval after the post-transplantation. So that can be 1 month, 2 months, 3 months, 6 months, or 12 months post-transplantation. That is the according to the transplant program choice or the protocol policy of the center. The purpose of this biopsy is early detection of acute or chronic graft dysfunction or rejection to improve the long-term graft survival and reduce the graft failure. So the main reasons for this detection of this thing is the subclinical rejection. If they are detected, they are treated, and so the graft survival is improved, and we can reduce the graft failure long term. Now coming to the rationale and practice of protocol biopsies. As a protocol biopsies are not universally practiced, even in the US kidney transplant programs, only 17% perform protocol biopsies routinely on all recipients. And other centers have reserved protocol biopsies for high-risk patients. High-risk patients means the patient who have cross-match positivity before the transplantation, they have elevated PRA level. So these kind of patients have higher chances of developing the rejection early after the transplantation. So centers believe that in these kind of patients or sets of patients, we should do the protocol biopsies or go for the protocol biopsies. Now coming to the timing of protocol biopsies. As said, there is no consensus on the optimal timing of protocol biopsies. Again, it is depend on the center. So it can be done after 1 month, 2 months, 3 months, 6 months, or 12 months post-transplantation. If see the older studies, in the era of less potent immunosuppression, they have saw that there was highest prevalence of subclinical rejection at the 1 month. So in that period, the immunosuppression was no very potent. So there are chances of rejection was very high. So people believe that in that era, 1 month post-transplant biopsies were indicated or for the protocol biopsies. But nowadays there is increased use of induction therapy. So there is a reduced incidence of early rejection, and that limits the utility of early protocol biopsies. So we know that nowadays most of the recipients are given induction therapy. So there are no point to go for the after early post-transplant period rejection for the biopsies, like 1 month transplant biopsies are not needed as such. So, but it should be based on type of induction treatment and recipient's immunological risk profile. In high-risk recipients, like with the delayed graft function or those with elevated PRA, 1 month post-transplant biopsies are suggested. And then follow-up protocol biopsy should be done at 6 months or 12 months post-transplant. Now coming to the logistics of the protocol biopsies. The risk-benefit analysis of protocol biopsy needs to be evaluated. The cost, effort, and time incurred in protocol biopsy, which includes physician time, laboratory tests required, pre and post biopsy observation, and follow-up could pose an enormous burden to the transplant center. And there is one more thing, that is a reimbursement for protocol biopsies from insurance provider will also play a role in the decision-making process for any individual centers. If you see the contraindications, they are coagulopathy or uncontrolled hypertension, and the major complications are seen in the range of 0.4 to 1%, that is a hematoma. So they are the contraindication and complication are same as with the indicated biopsies. Now there is some difference in the technique procedure, whether it should be wedge biopsy or the core needle biopsies. As we know that most of the biopsies are performed, that is the needle biopsy, percutaneous needle biopsies. But at the time of implantation, surgeon prefer to take the wedge biopsy. So these wedge biopsies are superficial biopsies, and they are generally just subcapsular region. So the subcapsular region have the more number of glomerular sclerosis, and they don't have the vessels because the vessels are situated deep inside. So in the cortical region. So whenever the wedge biopsy is taken, they underestimate the vascular regions and overestimate the glomerular sclerosis because of its shallow sampling. And that can lead to inaccurate assessment of chronic changes in allograft. Now coming to the implantation biopsies. Implantation biopsies are either 0-hour biopsy or 1-hour biopsy. So 0-hour biopsy means when the blood supply from the recipient has not been started. And the purpose of this biopsy is to observe the baseline graft condition of the donor. The donor may be deceased donor or the living donor. If you see from the deceased donors, kidney donor profile index, hypertension, diabetes, which may be underreported due to inadequate medical history. So we should go for the baseline graft condition and the biopsy should be taken. Even in the living donor, this uncovers the unexpected donor disease, especially in those of older than 60 years of age and with the history of hypertension. So basically, these are the marginal donors in which the history of hypertension are seen, and that shows some baseline biopsies are important to know the chronicity and it changes in the kidney. Next is the 1-hour biopsy. The 1-hour biopsy means the recipient blood supply has been started. And this biopsy involves an initial immunological reaction and reperfusion injury. Now coming to the main purpose for the protocol biopsy is the subclinical rejection, or known as SCR. SCR refers to the presence of histological features of acute rejection, which also includes the borderline T-cell mediated rejection with stable graft function. Means there is variation in creatinine value less than 25% from baseline, with no prior graft biopsy proven rejection. This SCR could be T cell mediated rejection or antibody mediated rejection. And these rejections SCR can be identified through only protocol biopsies. Now, if you see the rejection SCR incidence, true incidence are not known because the SCR reported by different centers are variable. And they are influenced by the recipient's demographics like characteristic of their HLA and ABO mismatch, timing of the biopsy, use and non-use of depleting antibody, maintenance regime use and steroid therapy, cold ischemia time and delayed graft function. And if you see the incidence of SCR, this was reported by the Nankivel et al. They have found that it is 2.6 to 25% within the first year. And the patients are on the tacrolimus-based immunosuppressions. Koi et al. Has reported incidence of IFTA, that is interstitial fibrosis and tubular atrophy, that has also the wide range, 0 to 79% reported in different studies. Now coming to the borderline changes. According to Banff classification, borderline rejection means there is tubulitis with the interstitial inflammation, and the score of the tubulitis should be T1, T2, T3 with interstitial inflammation, that is a mild interstitial inflammation, I1 level, or when there is tubulitis at the T1 with moderate interstitial inflammation, that is I2, I3 level. And it is detected in 10 to 15% of protocol biopsies during the first post-transplant year. And the subclinical borderline changes are not uniformly treated, and some studies suggest that withholding treatment in low-risk population does not lead to subsequent clinical rejection, at least in short-term follow-up. Basically, whenever the on protocol biopsies, borderline rejections are detected, few centers believe that this should not be treated because they feel that low-risk population, that is the patient who already has been given the induction therapy and on the triple immunosuppression. In these patients, if we withhold the treatment, even then in subsequent clinical biopsy, the rejections are not found. So, but other centers believe that subclinical borderline changes during the first post-transplant year increases the risk of persistent inflammation and higher grade of interstitial fibrosis and transplant glomerulopathy on 1 year protocol biopsy. So if you don't treat the borderline rejection, then chances of this inflammation, interstitial fibrosis, TG can be there. There's a high prevalence of this is seen. So this is a picture of a borderline T-cell mediated rejection. You can see the interstitial inflammation and there is tubulitis. So basically this is I1 with the T2, that is a borderline kind of T-cell mediated rejection. Now coming to the subclinical antibody mediated rejection. Patients with preformed donor-specific antibodies, despite aggressive induction antibody removal, 31% were found to have subclinical antibody mediated rejection on 3-month protocol biopsies. This was study done by the Lupi et al. And they also found that 49% had incomplete subclinical antibody mediated rejection, that is a microcirculatory inflammation with negative C4D staining. So whenever the high BSA is positive before the transplantation, sensitized patients, even when they go for the desensitization program, even them, they have found that in these sets of patients, almost 31% patient had the ABMR on the 3-month post-protocol biopsy. So this is the histological picture of antibody-mediated rejection. You can see the PTC inflammation, the peritubular capillaritis, and there are also the glomerulitis. And the C4D was positive, diffuse C4D positivity seen in the PTC membrane. That is a linear C4D deposition is seen, and the score is C4D3. So by microvascular inflammation with C4D positivity suggestive of antibody-mediated rejection. Coming to the chronic changes and prognostication. So Nankivell et al. Has reported almost 24 to 40% of the chronic changes. And these chronic changes could be immunological or non-immunological. Immunological, as we know, that is a rejection, chronic antibody or T-cell rejection. And non-immunological means there's some drug toxicities, viral infections. Any can lead to the, or any idiopathic cause can lead to the interstitial fibrosis and tubular atrophy. So if the higher chronicity score is there, it suggests a low graft survival. Now the thing is that if the fibrosis is associated with inflammation or not. If interstitial fibrosis is not associated with the inflammation, only the fibrosis is there, it represents the donor disease or previous injuries and maybe non-progressive. So the survival of the graft is quite good as compared to when the fibrosis is associated with the inflammation. And on 1 year post-transplant biopsy, if we don't see the fibrosis with the inflammation, the graft survival at the 5 year is quite better than only the fibrosis is there. So has a lower graft survival. So inflammation is not a good sign. So one should check when, especially nephropathology, should check interstitial fibrosis with inflammation is there or infiltration of cells are there or just only the interstitial fibrosis is there. So this studies by Nankivell and Swartz et al. They found that IFTA at the 6 and 12-month post-transplant, the risk factors are ischemia reperfusion injury, acute rejection, clinical or subclinical, early nephrocalcinosis, and donor age. And IFTA beyond 1 year, it could be associated with the rejection, donor age, or the cyanide toxicity. So these all things can lead to the IFTA in the graft. So here you can see there is the interstitial fibrosis with tubular atrophy without the inflammation. And this is the picture of chronic antibody-mediated rejections. There is a transplant glomerulopathy, that is TG or the CG, which is almost core is CG3. And there is C4D deposition seen in the PTCs. So suggestive of transplant glomerulopathy with C4D positivity. And this is a diagnosis of chronic antibody-mediated rejection. Now coming to the detection of some non-immune factor, that is the drug toxicity. So CNI toxicity is one of the culprit for developing of chronic changes in the graft. There is almost 42% recipients have found to have a cyclosporine nephrotoxicity in 12-month post-transplantation. The study by the Takeda et al. The important thing is that the cyclosporin toxicity, the CNI toxicity, can be of acute onset or the chronic changes. If we detect the CNI toxicity at early stage or during early phase, then it can be reversible by adjusting the immunosuppression or modified the immunosuppression dose. So here you can see the spectrum of CNI-induced histological changes. This is the acute stage of the cyclosporin toxicity where the tubules have the isometric vacuolization and the vessels are showing the hyalinosis, that is beaded kind of hyalinosis. And whenever there is advanced cases, it converts into the complete vessel wall is converted circumferential type of hyalinosis. And in the later stage of chronic stage, there is interstitial fibrosis, that is a strip kind of fibrosis. We can see the band of fibrosis with the normal tubules. If you go for the quite different spectrum of the CNIT, sometimes this vascular occlusion due to the hyalinosis can lead to ischemic changes and that can develop the collapsing glomerulopathy. Here you can see there is a proliferation of the podocytes with collapse of the tuft. And sometimes there may be chances of TMA in the early part of the CNI toxicity. Now coming to the polyomavirus nephropathy. So this is the picture histology of that. tubules are showing the viral inclusion, epithelial cells are showing the viral inclusion, and there is also the infiltration of the lymphoplasmacytic cells with tubulitis. And when we go for the IHC, that is SV40T large cell antigen, that shows the positivity. So this confirms the BKV nephropathy or polymovirus nephropathy. So the study shows the biopsy performed at 4 and 12 months post-transplantation. The incidence was reported 2.6 to 5%. So, and another study shows the BKV nephropathy has a reported incidence of 1 to 10%. And it can result into 45% graft loss. So it's a very high incidence of graft loss is reported. That is almost 50%, 45 to 50%. So if we detect early by the protocol biopsy, chances of improving the graft survival can be there. Another condition that is recurrence of glomerulonephritis. So different disease recurrent like FSGS, membranous nephropathy, IgA nephropathy, diabetic nephropathy. These conditions recur after the transplantation. Like IgA nephropathy, deposition of new IgA as the initial histologic lesion is often preceded by the clinical symptom like hematuria and proteinuria. So if we go for the protocol biopsy, we can pick up the IgA nephropathy when patient has still not developed the hematuria and the proteinuria. And the recurrence rate is almost 30 to 60% within 3 years transplantation. Diabetic nephropathy, this disease also recurs. So in this, there is almost 5 to 10 years after the post-transplantation, if protocol biopsies are taken, it gives the information about initial histological lesions in diabetes and its progression and prevention. So we can prevent the diabetic nephropathy disease if we go for the protocol biopsy early. Another lesion that is FSGS, this disease recurs very fast after transplantation. As we know, the proteinuria can be developed as early as post-transplantation. And membranous nephropathy, again, this disease recurs very fast. Like here, this is the picture of recurrence of the IgA nephropathy. You can see this immunofluorescence picture. There is a deposition of IgA in the mesangial region. The intensity is almost 3 plus. And histologically, you can see there is a proliferation of the mesangial cells, and there is FSGS. So this picture suggests you of recurrence of IgA nephropathy. This is the picture of recurrence of the membranous nephropathy. The membranes are thickened over here. And on IF, you can see there is a granular deposition along the GBM. The intensity is almost 3 plus. And when we did the anti-PLA2R, it was positive along the GBM. This confirms the recurrence of the membranous nephropathy. Now, coming to the incorporation of the non-invasive biomarkers and protocol biopsies. As such, we know that numerous studies over the last 2 decades on gene expression, donor HL antigens, cytokines, messenger RNA, and microRNA in allograft, blood, and or urine to diagnose the transplant acute rejections. So even in the antibody-mediated reaction, gene expression are also seen, higher gene expression are seen, and so they strongly favor the diagnosis of antibody-mediated reaction. So, but still, people believe that protocol biopsies or the biopsies are gold standard for the diagnosis of the rejection, because these biomarkers still need to be tested in larger study population to determine their true relevance and application. And even the validation of these studies should be there. Now coming to the diagnostic strategies for protocol biopsies, it can be divided into 3 parts. Either there should be no protocol biopsies, individualized biopsy, or the selected patient's biopsy, or biopsy should be done in all the recipients. If we select the no protocol biopsy, then we assume that either SCR is unimportant and can be ignored, or that is relevant but can be controlled by the high dose anti-rejection therapy. And this anti-rejection therapy can lead to the development of infection, viral infection. So whether to go for and there are always chances of missing the SCR. Few centers believe that it should be kept for the selected patients, means the patient who have the high risk individuals, and they believe that assumes SCR should occur in high risk patients and severe SCR will not occur frequently in low risk patients. In this policy also, there are always chances of missing the SCR in lower risk patients. Third is strategies for the universal screening protocol biopsy program. The advantage of this program is that simplicity of implementation, detection of unsuspected SCR in low-risk individuals, early detection of polymovirus nephropathy, and the disadvantage at this time, the cost, consumption of clinical and pathology, resources, workforce capability, travel and inconvenience to patients. So one should weigh the pros and cons of the protocol biopsies before starting the protocol program. Now we'll discuss the one index case. This is a 13 years old girl underwent deceased donor renal transplantation. Her basic disease was juvenile nephroptosis related CKD. The age of the deceased donor was 43 years and her serum creatinine level was 0.93. Baseline was 0.9 and she was on triple immunosuppression. So the biopsy was done, there's a protocol biopsy done after 1 year post-transplantation to see the changes of the kidney. So when we saw the biopsy, here you can see the inflammatory infiltration throughout seen over here and mainly in the region of the interstitial fibrosis. So this IFTA is there. So this is the, again, you can see the infiltration of the cells and there is evidence of tubulitis, mild tubulitis. Even you can say this is a silver stain showing the interstitial fibrosis, tubular atrophy. Glomeruli are almost unremarkable. So here also you can see this interstitial fibrosis with infiltration of the cell. And the C4D was negative. So if we summarize our finding, glomeruli was unremarkable, that is G0, CG0. Tubules a mild injury, there was focal atrophy for 15 to 20%, mild tubulitis, interstitial fibrosis were 15 to 20%, and there was mild monocellular infiltration. Blood vessels were unremarkable. There was mild infiltration of the PTC. The PTC capillaritis was there, PTC1, and C4D was 0. So no C4D depositions in the PTCs. So we keep the diagnosis borderline T cell mediated reaction with mild interstitial fibrosis and tubular atrophy. So in the 1 year post-transplant biopsy, where the creatinine level was almost unremarkable or the normal, there was no change or elevation of the creatinine level. The biopsy was performed to see the changes and the histological changes of borderline T cell mediated reactions with IFTA was reported. So very few studies are also published for the protocol biopsies because only few centers have the practice of protocol biopsies. This is a study from Indian study from the Kerala, Kochi, and this 2 year study out of 70 patients they have studied, 44, that is 63% had normal histology, 37% have the histological abnormalities. Out of that, almost 18% have the SCR, and some have the T cell reaction. Even the chronic TCMR was reported in one case, interstitial fibrosis, tubular atrophy in 5 cases, 7%, BKP nephropathy in 2. So they have also found all kind of histological features in protocol biopsy. Another study from the Spain, you can see over here, this was study biopsy were done at the 3 months post-transplantation, and they have studied almost 8 cases in which almost 41 had the normal histology and borderline changes reported in 12 cases, transplant nephropathy in 30, and borderline changes in 11 patients, rejection in 4 patients. So they have also found even so early, 3 months post-transplant have the histological features. So in conclusion, protocol biopsies are safe. Early identification of subclinical pathology and appropriate intervention improve the long-term graft outcomes. The cost, risk, and patient inconvenience of surveillance biopsy must be weighed against the potential gains from early intervention guided by the findings. Transplantation of high-risk, cross-match positive, highly sensitized, or ABO incompatible recipient, and use of extended criteria donors and donors after cardiac death also require careful, effective, and accurate monitoring using surveillance biopsy. So basically, this totally dependent on the transplant center whether they should start the protocol biopsy or not, because as such, there is so much of advantage of protocol biopsy as we have discussed. Thank you very much. This is the institute where I am working, Institute of Kidney Disease and Research Center, and Institute of Dr. H.L. Trivedi Transplantation Center. And we have also the university, Gujarat Institute of Transplantation Sciences. Thank you very much. And I'm happy to take.
Thank you, sir. Thank you for this lucid presentation. And by quoting all the national, international studies along with the index case at the end with the clinical scenario. As you said, like early detection maybe will reduce the chances of graft loss and improve the graft survival. So the questions are there, sir. Can we take up the questions? Is there is there any criteria of proteinuria cutoff for definition of subclinical rejection?
So there is no criteria for protocol biopsy for proteinuria as such. But as such, we know then if the proteinuria is there, then we should come to know the reason for that. Why the transplant patients should develop the proteinuria post-transplantation, and at what level the proteinuria is there. Suppose we get the subnephrotic range proteinuria after 1 year transplant biopsies, we should always think in the terms of some rejection also, or sometimes in the chances of recurrence of the disease. So if we know the basic disease, then always there is possibility of recurrence of glomerulonephritis. So if we go for the protocol biopsy, there are always chances that to pick up the disease. As I have mentioned in my recurrence of the disease, like membranous nephropathy or in the IgA nephropathy, where the patient still doesn't develop the hematuria and the proteinuria. In that scenario, also, if you go for the protocol biopsy, then sometimes you may pick up or detect the lesion. And if we treat this kind of patient, chances of recovery or in the transplant interstitial fibrosis and tubular atrophy will be reduced, and we can improve the graft survival. The main purpose of this protocol biopsy is if we get any rejection or any disease, if we treat it, then the long-term survival of the graft will be increased.
Yes, sir. So in centers doing protocol biopsies, are 3 cores taken for biopsy every time, sir? One for like LM, then IF for
Yes.
EGM.
If I talk for my centers,
Yes, sir.
generally the pediatric group is doing the protocol biopsies. And generally they are getting the 2 cores only.
Yes.
And in like for one for light microscopy, another for the IF. And for the EM, we take from that 2 cores. So that is enough for that. 2 cores are always better.
At least 2 cores for
2 cores is always enough for this any biopsies.
Yes, sir. Sir, for immunofluorescence, like immediate post-transplant, like how many months after post-transplant do you recommend to have the second core, or every time we should have at least 2 cores, as you said?
Sorry.
Immediate post-transplant duration, how many
Yes.
months after do you recommend
Some
to
disturbance, some disturbance is going, I think, in between. Yeah. Just can you repeat the question? I'm not getting
Yes,
it.
sir. Yes, sir. Yes, sir. No, after the post-transplant, like how
Yes.
many months after you recommend to, you must take the other core for immunofluorescence to look for recurrence or deno, like that, sir.
Do you
Or for
mean that,
every protocol,
see,
or for every protocol biopsy, we should have 2 cores, LM and IF.
no. At such, whenever this is program is dependent totally on the transplant centers. Like as I mentioned,
Mm-hmm.
few centers are regularly doing after 2 months, 3 months, 6 months, 12 months. So frequent biopsies they are doing. And few centers, as I mentioned,
Yes.
that in this type of the patient, because already the patients are on the induction therapy. They already given the induction therapy before the transplantation. So there are chances of recurrence. I mean, the rejection is very less. So whenever the biopsies are taken, generally in our center also they are doing the biopsy at the 6 months or 12 months post transplantation. So for the recurrence of the disease, generally, if you think what kind of recurrence is there, so if you go for the 12-month biopsy after post transplantation, that will be more helpful. And sometimes if the proteinuria is there, like in FSGS,
According to that.
membranous,
Okay.
is that according to that, in that scenario, if you go for the protocol biopsies as early as possible, that may help you to detect the disease.
Sure, sir. Yes, positive C4D staining with no microvascular inflammation, whether we have to call it as subclinical ABMR and treat, that is one of the questions.
Positive C4D, as such, nowadays, the band classification has revised their policy also. Over that,
Yes.
see, C4D is, as such, is needed to call as a uh, antibody-mediated rejection. But if you don't get microvascular inflammation and there is only this ATN kind of things are there, in that scenario, it's always there are chances, the probability of ABMR is there. But if you get the microvascular inflammation associated with the C4D, then and the DSA is there also, then it's a complete kind of diagnosis for ABMR.
Sure.
Yeah.
Why C4D is seen only in the PTC, peritubular capillaries, and not in the glomeruli or vessels?
Yes. So there is, as the complement things are there, the PTCs have this endothelial cells where they attach with that, and there is bonding with that. So and that can lead to the deposition, and they are not. I mean, in glomeruli also you would see the C4D deposition that is in the mesangial region, not in the capillaries as such. Sometimes you may get the C4D deposition in the GBM also. That is again, it may be showing chronic type of rejection when associated with the PTC membrane deposition. So you have to see, check for everywhere. But C4D deposition in PTC is kind of ABMR.
Yes, sir. Yeah. Those were the questions,
Yes.
I think. Yes. So thank you, sir. Thank you, I sought, for giving us the opportunity to hear from the renowned speaker. Thank you very much.
Thank you.
Thank you, dear all contestants. Thank you. All the attendees, thank you.